First, let's start with cardiovascular physiology. And I've made some choices what to talk about and what not to talk about because it's huge, the subject on cardiovascular physiology. And what we all know, what's the circulation for? Well, it aims to deliver oxygen and nutrients to the tissue, and it's used for removal of carbon dioxide and waste products. And if you look at the circuit, we've got the right heart. It pumps the blood through the lungs, the right ventricle output, with the pulmonary blood flow coming to the left heart, coronary blood flow going to the heart again, left ventricle output, ascending aorta output, descending aorta output going to the lower body, and then the venous blood is coming back again with the venous blood coming from the upper body. You have here the SVC flow, and together it is the venous return. What makes the blood flood? It's like a waterfall. And what you need is a pressure difference. It's the driving force. There's a upstream pressure, a downstream pressure, and the difference between those two is the driving force. And flow is determined by the driving force divided by the resistance. The greater the resistance, the lower the flow will be. And it's often referred as Ohm's law, but the Ohm's law is for the electronic circuit, and when you apply it to fluids, it's called the Hagen-Poiseuille law. But we can translate that to cardiac output and arterial blood pressure. We've got the Hagen-Poiseuille law, but the flow is cardiac output. The pressure, the driving force, is arterial blood pressure, and to be complete, it should be minus the right atrial pressure and divided by the systemic vascular resistance. And that's what we know from the clinic. Blood pressure is not equal to cardiac output, but it depends also on systemic vascular resistance. So you can have a very normal blood pressure with a very low cardiac output when systemic vascular resistance is high. The cardiac output is determined by stroke volume and heart rate. And you see a dotted arrow between heart rate and stroke volume because the heart rate also influences stroke volume. The higher the heart rate, the shorter the filling time, and with that you can have a lower stroke volume. And as we all know, stroke volume depends on contractility, preload, and afterload. And let's discuss these subjects. Starting with contractility. Calcium, the calcium ion in the concentration of calcium is very important for myocardial contractility. And how does that work? If you look, when you first got the cardiac action potential that induces the depolarization activated calcium channels with an influx of calcium into the cell, it triggers the sarcoplasmatic reticulum to release more calcium. It increases the free intracellular calcium in the cell, which takes care of the binding of the myofilaments and the interaction of actin and myosin, and it will result into a contraction. Not only contraction is very important, also the relaxation, and it's in the opposite direction. You have to have a calcium transport out of the cell, and that's by these four systems which will decrease the free intracellular calcium concentration, and with that it dissociates from the troponin and results in a relaxation. We all know that for a contraction we need an interaction between actin and myosin. Here you see the myosin, actin filaments, the tropomyosin, and the troponin. Calcium is used to bind to the troponin, and then the myosin binding sites will be exposed, so there can be an interaction between the myosin and the actin. And with that, you can have the circuit of contraction with the flexure of the head of the myosin filament. The contractile force of a muscle depends on the length of the sarcomere. And there is an optimal length of the sarcomere with a optimal, highest contractile force. And that is what's seen in this figure. On the x-axis, the sarcomere length, on the y-axis, the contractile force. And the higher the sarcomere length, you can get an increase in contractile force, but until an optimal, and after that, increasing sarcomere length won't increase contractile force. And instead of sarcomere length, you can put in here the ventricular and diastolic volume, also known as preload, and for contractile force, stroke volume. And this curve is known as the Frank-Starling curve. And the Frank-Starling mechanism, that is the change in contractile force in stroke volume that is in response to a change in venous return and diastolic volume. Normally, the curve will look like this. And when contractility is decreased, you get a more flattened curve, or when you increase contractility, for example, with inotropes, you got a more steeper curve. With just a slight increase in preload, you get a high increase in stroke volume. Well, we all take care of children, newborns, preterm newborns, and there are some developmental changes in the cardiovascular system. And when we look at contractility, when you see the immature myocytes, it's quite a difference. These are pictures from an adult rabbit and a newborn rabbit, and what they saw in this study is that there are a lower number of myofibrils per cross-sectional area in the newborn rabbit muscle. There's an impaired internal organization, and they contract more slowly and by a smaller amount. And the net effect is that there is a less force of myocardial contraction. When you look at ventricular tissue that has been obtained during surgical repair of a cardiac disease in both newborns and infants, they've looked at how good it was for the muscle to contract. And what they did is they paced the muscle fibers with an increasing frequency, so a lowering of the cycle length. And let's first look at the slide, at the figure of the infant. When you increase frequency of pacing, you get both an increase of contraction frequency and an increase in contraction force. If you look at a newborn, you can see that there's an increase in contraction frequency, but no increase in contractile force. And when you look at the timing, you can see in the newborn that there is a shortening of the contraction, but no increase in contraction, as shown here. Well, while in the infant, you get a shortening, but an increase. So what you can say is that shortening the pacing of the cycle length, it doesn't increase the force in newborns. It's called a flat force-frequency relationship. And despite this flat relationship, there's a large increase in frequency-dependent acceleration. And the net effect is a shortening in contraction. If you look at the cellular level, there's quite a difference between what you see here on the left side, newborns, and here older children. A lot of mechanisms involved in calcium handling are quite different. The T-tubules are more sparse in the newborn and they develop over the first year of life. The sodium-calcium exchange mechanisms is also more sparse in the newborn in comparison with the children, and also the sarcoplasmatic reticulum calcium influx mechanisms are quite different, as you can see in this slide. In rabbit hearts, they have measured the intraventricular pressure and flow, and what you can do is during a contraction have a look at the ventricular pressure, and you can determine the pressure difference over a particular time during the upstream of the arterial blood pressure wave. It's called the dp/dt max, and that's a parameter for contraction, and the dp/dt minus, that's a parameter for relaxation. And what you see is the postnatal age. During the first week, there's a large increase in contractility, a large increase in relaxation, up to a level of 45% for the contraction and up to 75% for relaxation. So, significant increase during the first week of life in contractility and relaxation in this rapid animal model. They also looked at the response to inotropes, and in this slide I show you the response on isoproterenol. And when you look at dp/dt max, so the contraction, you see the difference between the younger and the older rabbit's heart. Also, when you look at the relaxation, also a clear difference between the younger and the older rabbit muscle. So significant differences in the response to inotropes on both the contractility and relaxation during the development of the heart. So let's talk about preload. Preload, in fact, is the degree of the myocardial distension prior to the shortening of the myocardial muscle fibers, and it's related to the end-diastolic ventricular volume. In fact, it's related to the length of the sarcomere. And we already saw this Frank-Starling curve. Increase in preload to a certain extent will increase stroke volume. And you can say that preload is a sort of tailwind for the patient. And there's a quite difference in the Frank-Starling curve between the fetus and a mature myocard. What you can see here, that the fetal myocardium is continuously on the flat part of the Frank-Starling curve in comparison with the mature heart. The fetal myocardium has a limited preload reserve, and that's related to the immature myocardial architecture with a very poor compliance of the fetal heart. That's also shown in this slide, where they looked via fetal echocardiography on the inflow over the mitral valve. And what you see normally in a mature heart, in adults, there's a higher E wave that corresponds with the early filling of the ventricle, and they have a higher E wave than the A wave, which corresponds with the active and atrial contraction. But in the fetus, it's quite the opposite. A small E wave, a large A wave, and that is due to a low compliance of the fetal myocardium. Why is it a lower compliance? And that's because of the relatively high amount of the total collagen in the heart and the high ratio between type 1 and type 3 collagen. And type 1 collagen in the heart is responsible for rigidity, and the type 3 collagen is responsible to elasticity. So if we look at the total collagen per milligram heart during development, this is early life, This is at 18 years old. This dotted line represents the mean adult value. And in general, you can see the total collagen is above the mean adult value. But more important is that the ratio between type 1 rigidity versus type 3 elasticity, that's increased in the very young children. And that's why there's a lower compliance in the younger heart. Brings us to afterload. The afterload is in fact the force against which the heart must pump, and it's the tension that's experienced by the sarcomere. It depends on arterial blood pressure and vascular resistance, and it's demonstrated in the Lame's equation that the ventricular pressure, it depends on the transmural pressure in the ventricle radius, the ventricle wall thickness, and an increase in afterload will decrease the velocity of fiber shorting. An increase in afterload will decrease contractility. What you can see over here, that the ventricle wall stress depends on the ventricle wall thickness. So when there is a hypertrophy of the myocardium, it will decrease ventricular wall stress, it will decrease afterload. If you get a dilatation of the ventricle, it will get an increase in ventricular wall stress, an increase in afterload. This is the relation between, on the x-axis, the wall stress, afterload, and on the y-axis, contractility, velocity of fiber shortening. And the higher the afterload, the lower the contractility. But one should note that afterload is not exactly the same as the systemic vascular resistance. The systemic vascular resistance is of influence on blood pressure, but blood pressure is only one of the determinants of the afterload, which we already saw in this equation. So it's too simple to say afterload is the same as systemic vascular resistance. Looking at developmental physiology, during the first year of life, you have an increase in myocardial wall thickness, an increase in left ventricle mass index. This is from a study in newborns using echocardiography. It's known that the fractional shortening is unchanged with age. But what you see is the difference between newborns and older children. You see a more steeper slope in newborns with an increase in afterload. There's a more intense decrease in contractility in comparison with older children. What you can see also in this slide is that at a certain amount of afterload at wall stress, the contractile force is higher. So you can state that newborns are at a higher basal contractility. Another study, also echocardiography in preterm, full-term, and older children, and you can see the difference in the slope in the relation between wall stress, afterload, and contractility. A remarkable difference between preterm, term, and older children. So the left ventricle performance in preterm and full-term infants is highly dependent on afterload. As we already told, newborns have a higher basal contractile state. This is the difference between newborns. They are higher up the curve than children. I've put it in a slide like this. It's not on a good scale, but it's more a representation that newborns function on this side of the curve with very dependent on afterload, and adult or the mature myocardium are not that dependent on afterload. But we all know that changes in preload and changes in afterload, there's an interdependence between those two. And that's been shown in a study in a fetal lamb model where they looked at the correlation between the mean arterial pressure and stroke volume in a fetal lamb with different left atrial pressures, different preload. And what you can see when you increase preload, you can increase the contractility despite a higher mean arterial pressure. So a higher preload can compensate for some extent for a higher afterload. Brings us to heart rate. As you all know, an increase in heart rate will increase cardiac output. But I already told ventricular filling time is dependent on the heart rate. And there's some optimal heart rate for the cardiac output. And one should note that when there's a tachycardia that will persist too long, that will result in myocardial fatigue. Another concept I would like to introduce is the venous return. And I got very interested in this because it was quite new for me. I didn't realize that most of blood volume is on the venous side. About 60 to 70% of blood is in the venous side. And the arteries only contain 15% of total blood volume. And there's a factor 30 of more compliance in the veins than in the arteries. And there can be a substantial change in blood volume in the venous side without any change in the transmural pressure in the veins. So in that sense, it's an ideal reservoir for blood. And the most compliant veins are the splanchnic and the cutaneous veins. And it's also very interesting that there are much alpha-1 and alpha-2 adrenergic receptors in those veins. I will come to that later. So let's have a look at systemic venous return. We already saw the Hagen-Poiseuille's law. We use that for the cardiac output, but can we also use that for the cardiac input, venous return? Yes, we can. What we need is a driving force. The driving force for the venous return from the tissue to the heart is the difference between this pressure and this pressure. Here it is the right atrial pressure, and the pressure in the tissue is called the mean systemic filling pressure. So the venous return is the difference between mean systemic filling pressure and right atrial pressure, and also in this flow is dependent on resistance in this circuit. If we want the blood to flow from the toe back to the heart, you need that driving force. And in this figure, I've got the right atrial pressure, and when there's a decrease in right atrial pressure, there's an increase in the driving force, and you get an increase in the flow. So decrease in right atrial pressure will produce an increase in venous return. There is a maximum when the right atrial pressure is at 0 because of a venous collapse that will occur with a lower right atrial pressure. There's no more increase in venous return. Interesting is that you can say at this point when there's no venous return, right atrial pressure must be equal to the mean systemic filling pressure. When we look at the venous system, when we fill it up with fluid, at first it won't increase the venous pressure because it just fills up the system, and that is called the unstressed volume. When you add more fluid to the venous system, that will increase the pressure in the venous system, and that volume is called the stress volume. stress volume is that amount that when added to the unstressed volume generates the vascular transmural pressure. It's a driving force for the blood from the peripheral tissue to the heart. It determines the mean systemic filling pressure and therefore is of influence on venous return, and what goes in must come out, or other way around, what comes out must first come in. So in this circuit, the venous side, I think it's better to draw it like this. There's a great reservoir where the blood is coming. There's a unstressed volume, and there is a stressed volume. And the column of stressed volume is the driving force for the venous return. And remind you, there's a rather large, there are large, many adrenergic receptors on the venous side. So, for example, norepinephrine, we all think about the atrial effects with vasoconstriction. But you should also look at the venous side. It provides a venoconstriction. And with that, you can change the unstressed volume by constriction over here and make it a stressed volume, increasing mean systemic filling pressure, increasing venous return, and in that way, increasing cardiac output. So during the sepsis with norepinephrine, it's, I think, not only the arterial side that's effective, but it's also the venous side with mobilizing fluid into the active circulation, increasing stress volume, increasing mean systemic filling pressure, increasing venous return, and by that increasing cardiac output. Well, there's an interaction, of course, of venous return and cardiac output. What comes out must first come in. So let's draw the venous return curve again, and we saw that already. And let's also draw the Frank starting curve. And this is the point where venous return equals cardiac output. And that is the point that this patient is functioning at this moment. What happens when we have a ventricular failure? What will happen is that the Frank starting curve, the cardiac output curve, would be like this, a decrease. Venous return is the same. What it means is that you get a lower cardiac output at a higher right atrial pressure. What happens when we increase venous return? What that will do is, we'll go over there, that's the point of where the cardiac output equals venous return. You get a higher cardiac output at a higher right atrial pressure. It's quite interesting to look at mean systemic filling pressure. Recently, it's been introduced in adult critical care as one of the parameters that can be used to determine whether or not a patient is volume responsive. We all know that we're very eager to give a volume expansion to patients when they're at a low blood pressure, etc. But we also know in newborns that it's not effective. Most newborns aren't in a hypovolemia. And when it does something on blood pressure, it's only for 10, 15, 20 minutes, except for the cases in fluid loss like a solutio placentae or something like that. So we're looking for parameters that will tell us how will this patient react on a fluid challenge. Is there a good chance that this patient will profit from a volume expansion? And maybe we can determine the mean systolic filling pressure. When that's low, then you can say we can increase it by giving more fluids or giving norepinephrine or give a venoconstrictor or whatever, and we can try to help that patient. It's very difficult to measure mean systemic filling pressure. The first time it was described in 1897 by Frank, from the Frank starting curve. And it was the pressure that's in the vascular system at a cardiac arrest. When you're in a cardiac arrest, there's an equilibrium between the arterial and the venous side. And the pressure that's in the circuit at that moment is called the mean systemic filling pressure. No venous return, no cardiac output, it's the pressure in the vascular system. And we can mimic that, and that's what my colleagues on the adult intensive care have done, by a very fast occlusion of an extremity of an arm where there's a peripheral arterial catheter and a venous catheter. And you have to do it very fast because there should be no more in or outflow. What you see, the arterial pressure at occlusion, you've got a decrease in arterial pressure and you've got an increase in the venous pressure. And when it's equilibrated, that is called the mean systemic filling pressure. What you see over here is the most perfect figure with a practically equal venous and arterial pressure. What we saw in more patients, normally there's a difference between those two. And this mean systemic filling pressure is used in the adult in critical care, so mind you, this is for adults, as a predictor of volume responsiveness. And what you see is that it's over here, it has a high sensitivity and a relatively high specificity. So I was very curious whether or not this would work in a newborn infant. I'm very sorry, this is very light picture. But last week I got the permission from the ethical committee to do these tests also on a newborn infant. And it was a radial artery in a full-term patient and a normal venous IV put on a pressure transducer. And what you see is after fast occlusion, you've got a decrease in the arterial pressure and an increase in venous pressure. And what you notice is a difference. Venous pressure is increased over the arterial pressure. And I think that's very strange because there is an open connection between those two systems. And why does it increase on the venous side? But this is what we also see in most of the adult patients. And we don't know yet. And if you've got any suggestions, I would be happy to know. Only thing I can think of is that there must be a compartment on the venous side, otherwise you can't have a higher pressure. Maybe it's related to venous valves. I can't think of anything else. When there's a venodilation, constriction, or on the arterial side, it also should equilibrate. So it's not only about pumping the blood around, it's also about oxygen balance. And oxygen delivery should be sufficient for oxygen consumption. And oxygen delivery depends on hemoglobin, the oxygen saturation, and the cardiac output. Hemoglobin and oxygen concentration are the main determinants of the total arterial oxygen concentration, and to a lesser extent also the PO2. And this equation is for the hemoglobin in millimoles per liter and the PO2 in kilopascals. If you look at high oxygen contraction, there are several types of organs. You've got the high extraction organs like the heart, brain, muscle, highly dependent on blood flow, and the low extraction organs like liver, kidney, and skin. And this can be used for the redistribution. In the beginning of a shock, your blood will redistribute from the non-vital organs to the vital organs. But there is a critical point at which the systemic oxygen transport limits the oxygen consumption. And that is shown in this slide. On the x-axis, the oxygen delivery, and look at, here is the oxygen consumption. And when oxygen delivery is decreased, there is a critical value at which below that amount of oxygen delivery, it will result in a dependency on oxygen delivery. And if you look at oxygen extraction, it will increase, and the venous oxygen saturation will decrease. It's quite interesting parameter, the venous oxygen saturation. It reflects the relationship between the oxygen supply, and remember, suppose we've got a stable hemoglobin level, then saturation is the main determinant of oxygen concentration. You can say this is the supply of oxygen, there's oxygen consumption, and this is what is left, and it's the mean, the mixed venous oxygen saturation. It's rather difficult to measure mean of the mixed venous oxygen saturation. You should sample that in the main pulmonary artery, and you need a pulmonary artery catheter, a Swan-Ganz catheter, and that we can't apply in newborn infants. So what we use is a surrogate, and that's central venous oxygen saturation. But as you can see from this figure, it depends very much where you sample the venous oxygen saturation, because there's the difference between central and mixed. It depends on the sampling site. Is it after low extraction organs of the high extraction organs, the presence of shunts, the redistribution of blood flow, level of consciousness is of influence, and the myocardial oxygen consumption, because the coronary sinus comes in the right atrial and decreases the right atrial oxygen saturation. Then, the last item, last subject, is the cardiopulmonary interaction. When a baby is on a ventilator, it has an interaction with the circulatory system. What you see over here is a mechanical insufflation, increased pressure, that will increase both the pleural pressure and the transpulmonary pressure. The higher pleural pressure will decrease right ventricular preload because of a decreased venous return. There's an increase in right ventricular afterload, and that both will result in a decrease in right ventricular ejection. And after the pulmonary transit time, it will decrease left ventricle preload and left ventricle stroke volume. On the other side, the effect on the left ventricle are quite the opposite. The increase in pleural pressure will decrease left ventricle afterload because of a decrease in pressure gradient. It increases left ventricle preload because of its blood is squeezed out of the pulmonary circulation, and that will result in an increased ejection of the left ventricle and an increased stroke volume. So at the end of the inspiration, there will be a increase in stroke volume. What you see is a maximum of systolic pressure, pulse pressure, and aortic blood velocity. And on the other side, at expiration, there will be a minimum of these parameters because of a decrease in left ventricular stroke volume. That's what you can see, and we possibly see that on our monitor, but we don't always look at it, that you see an arterial blood pressure variation during inspiration, expiration. In fact, what happens is this. When there's inspiration, you get an increase in preload on the left ventricle and an increase in stroke volume. This is what you can use also in larger children, in adult patients. We don't know yet in newborn patients to determine whether the patient is fluid responsive or not. Let's see in the hypovolemic or the normal volemic patients, ventricular end-diastolic volume is low. When you increase preload, there will be a large change in stroke volume, so there will be a large variation in arterial blood pressure. On the other side, when you're hypervolemic, you're on the steep part of the Frank-Starling curve, and an increase in ventricular end-diastolic volume won't have that much effect on stroke volume, and you won't see that in the arterial blood pressure variation. What can you do? How can you measure arterial blood pressure variation? You can measure the variation in pulse pressure, the maximum and the minimum, or you can have a look at systolic blood pressure variation. I've looked at our department at blood pressure variation in newborn infants, both preterm and term, and what we see is that when they're on the ventilator, SIMV without triggered breath, you can see that during inspiration there indeed is an increase in arterial blood pressure. As you can see, during spontaneous ventilation, it's the inverse, and that's how it should be, because during spontaneous ventilation, there's a negative interthoracic pressure, so the reverse effects on the circulation. We even can see arterial blood pressure variation on high-frequency ventilation. But what we notice is we can't measure it in a way. All the formulas that are used in larger children or in adults, we can't use that in newborn infants. Why not? The adult critical care has shown that when there is a heart rate to respiratory rate ratio between 3.6, in other words, after one breath, you should at least have 3.6, but 4 heartbeats to effectively analyze arterial blood pressure variations. But in newborns, we've got a much higher heart rate to respiratory rate ratio. On the x-axis, I've shown here the heart frequency, and with these lines, I've put several ventilator frequencies, 20, 30, 40, 50, and 60 beats per minute, breath per minute. And as you see, mostly we're working in the area with a lower heart rate to respiratory rate ratio. So I think volume responsiveness prediction with heart rate variability is rather difficult in newborn patients, and we're still working on it, whether or not it is possible. Brings me to a summary. Developmental changes have major impact on cardiovascular physiology and pathophysiology in newborn infants. Cardiac output must equal cardiac input, systemic venous return. Venous return is determined by stress vascular volume, in other words, the mean systemic filling pressure, venous compliance, resistance to venous return, and right atrial pressure. And most of all, it's not the oxygen delivery that's important, the macro circulation, it's the balance between oxygen delivery and consumption on both the global and on the regional level. Thank you very much for your attention. Are there any questions? Yes, please.
I have a question. First, a small comment on the difference between the arterial and venous pressure during occlusion. Maybe it's because of the continuing inflow through or via the nutritional vessels of the bone. Because you might have a continuing inflow causing a continuing increase of the venous pressure, and you measure your arterial pressure in another vessel, perhaps.
Yeah, we thought of that, but go to the microphone. What is a prerequisite of this method is that you've got a fast occlusion and a total occlusion, so increased pressure up to 100 millimeters of mercury. So it's far
not the bone. You have a small inflow continuing through the nutritional vessels of the bone. If you have it on the upper arm or...
Yeah, it's on the upper arm.
There might be a continuing inflow through the bone.
Yeah, but then it's still my question, because it's an open connection between the arterial and the venous side, why there must be some compartmentation or something like that, and the only thing I can think of is...
I don't know it.
But you're right. When there's a very small inflow that's not compressed with 100 millimeters of mercury, then I would expect that both arterial and venous pressure would increase. But I can't explain the difference between those two.
The second is the hydrostatic pressure. We know that the venous return is very dependent on the hydrostatic pressure on the positioning. What does the positioning of the newborn play? Does it play a role or not?
That would definitely play a role. but fortunately all neonates are in a supine position, and in that way it doesn't have any influence. But it's very interesting to have a look at the influence of the position of the incubator, etc., on the mean systemic filling pressure. And that will influence also if there is a cutoff value on which you can say, well, this is really low and we can expect this patient to be volume responsive. We should take that also into account.